Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to give my takeaways from the 2024 American Society of Shockwave. This was a conference that was held in Boston. And by the way, if you're listening to this and you want to kind of get my take on Shockwave and kind of my resources, if you go to podiatrypracticemastery.com/Shockwave, or if you look on the bottom of that main page, there are my Shockwave resources, which has kind of links to slides from the Shockwave conferences, all of my notes, different things like that. Okay, so this was a good conference. It was a 2-day conference, Saturday and Sunday. The only drawback, it was Saturday and Sunday. The good thing is you don't take time away from the office. There were, as typical fashion, there was a lot of European lecturers because they've been doing this a lot longer than we have. And then the last portion on Sunday were the kind of the U.S. researchers. It was a good conference. A lot of great lecturers talking about Shockwave using for arthritis, using Shockwave for different types of pathology, the kind of the science behind it. There were 3 different machines there. I think 2 are kind of the same. I think the Novus and the Curamedics are the same Storz device, and the other one was Softwave. There were good lectures by everyone. I found it beneficial just to kind of build up more confidence. It was nice because the room was filled. There was probably about 150 people there. I was really surprised that there wasn't more podiatrists. There was really the same group that tends to go to a lot of these conferences, and there were a lot of chiropractors, physiatrists, massage therapists, and really the takeaway is really making sure we have the proper diagnosis when we're doing these things and not kind of rush into treatment. So what are some of my main notes? I'm basically going to read my notes here for you because some people don't go to look at these resources. To penetrate, go into the bone, you need to kind of numb up the area with about 500 pulses, and then you can gradually increase your intensity. So you might have to start slow, and there is an analgesic effect by hitting the same area, and then you can get up. But also for arthritic changes, you don't always have to get to that 0.25 to 0.3 for bone penetration to get beneficial effects. And that's something I had to take away because I've been many times making my patients almost cry when I'm doing arthritis, and I don't think you need to go that high. Also, it's also important in each session to use the ultrasound and also to point. And then that's the way you can find the location for the anatomy. One good idea was you point where it hurts, and then you use a pen to mark kind of at the noon position and the 3 position, and then kind of treat around that shockwave area about the maximal pain. So using kind of trigger point areas or point of maximal pain, marking that every single time, and possibly even using the ultrasound every single time to just verify the anatomy. So everyone tends to use ultrasound. So once again, if you're doing Shockwave without ultrasound, I think it's harder. I think if you have ultrasound, it makes it easier. Also, my other takeaway is reducing my intensity. I think I've made mistakes where I'm doing much more intense, especially for, like I said, arthritis and bone marrow edema. I'm not using it a lot for wounds. I think there's some place for wounds. We have a Softwave where it's kind of made for wounds, and we've tried to bill out a few times, and we've gotten paid for Softwave for like Medicare patients, so which is kind of a good thing. Or bad thing, it depends. Also using it for severs. That's something I really haven't used it a lot for. Another thing that was recommended was considering the RMTI, which is called Regenerative Medicine Training Institute. It's a way that you can learn how to do other types of regenerative treatments such as PRP, bone marrow aspirate. We are not doing that. We were doing a couple of different types of amnio products. The PRP, we kind of shied away from it because we didn't like to draw the blood, but I'm not exactly sure because the amnio is now harder to come by. So that's kind of what we're doing. Novus was a company I hadn't heard of before. I guess they have some surgical plates, but they also have 2 different types of Shockwave machine. They really look like an older, cheaper model of the Curamedics or the Storz device. Softwave is an unfocused device, and I kind of learned that the focused Storz device is electrical, and the unfocused is hydraulic. And it's good for wounds covered by Medicare. I think what I appreciate with Softwave is that once again, we have 2 radial devices, one in each office, and we have a focused in our Worcester office, and we have an unfocused in our Worcester office and a focused in our Westboro office. So we're trying both of them. We're finding very similar effects. I think the Softwave is a lot easier to use, just less settings you mess with. and it might be one that's covered by insurance, which is a good thing. And so once again, radial and focused were the kind of the workhorses. Kind of reminding everyone about how people learn. And this is something, just they went over this again. So lecturing is good, reading is good, audiovisual is good, but really demonstrating and discussing and practicing are better, and then teaching is the best. So when we're teaching patients and lecturing to them or reading something for them or showing them a presentation, I think that increases the amount that they're going to retain. But I really think we need to, and this is what I've learned, you have to do a recap at the end so they know what they're going to remember. But I think reading and showing them and even demonstrating kind of what's going on with them is going to help with their learning and explanation of what's going on. So since only 5% is remembered after a lecture, after a couple weeks, then you have to recap so they know what they're going to remember. So another thing that was emphasized was under-promising and over-delivering. I think this is important. So when we're doing this, many times we're saying, this is going to hurt a lot, and then it's not going to hurt that much. Or the results are going to take 6 months, and many times they're going to see it after 6 weeks. Also for like a plantar fibroma, I use it for a little bit for fibromas, but using it can help the elasticity and reduce the pain, but many times it doesn't reduce the actual size of the fibroma. Once again, for arthritis, which I talked about before, start low and slow, and then ask about pain. And this is something I don't typically do, but I as they were demonstrating, they'll ask the patient, so 0 is no pain, 10 is the worst pain ever, your number should be around 5, so let me know how you're feeling. And so they gradually increase things. For arthritis, there was a doctor, Dr. Leal, and he talked about doing biomechanics, controlling the load through arthritic joints, which would be for us, would be like orthotics, controlling the load, doing possibly some laser, doing some shockwave, and then he does hyaluronic acid injections. We don't tend to do that, but he has this regimen where he does these 3 shockwaves, injection, and then they see them back once a year. So every year they kind of say to avoid doing a replacement, you can just do an oil change. So he calls it an oil change, doing it back once a year for arthritic changes. I kind of like the idea. So I thought that was kind of unique. Severs, I think this is something that I'm under-treating, so I'm not doing a lot of shockwave for it. And I think the main reason is because I was heavy-handed one time and the kid never came back. I think they were crying. So doing it a lot less intense, and also talking to patients about using turf shoes versus cleats. I think turf shoes, I learned this from Amal, is that turf shoes are a lot less aggressive and less painful. Ulcers, doing it for ulcers, once again, when you're doing an ulcer, you have to put it in like a Ziploc bag or one of these. You can buy the actual ultrasound covers, but they're like 50 cents, or you can just use a Ziploc bag and put gel on the inside, remember, inside and the outside. And then also in terms of wording, there's different like wording, like when this is a couple of phrases that I got there from one of the lecturers. For plantar fasciitis, when the morning pain is gone, it's usually resolving. For Achilles pain, when it's no longer painful going down the stairs, it's usually resolving. And then something I've never done before was something called a functional hop test. Basically, you hop on one foot. So if there's no pain with a tendon or fracture on the hop test, then they can get back to activity. There was a couple of great lectures on tendons, specifically University of Delaware. There was a doctor there, and she kind of talked about tendon health, and also talks about like how to individualize treatment. And they have this little diary that I included in my notes here, where you have the date, you have the home exercises, and then running or jumping, physical activity, and what their pain level is. And this is something good just to monitor like improvement on a visual analog scale, and kind of telling patients where their pain, where it's acceptable to have pain. So it's acceptable to have pain level less than 5, but over 5 they're doing too much. So I like that idea. So in general, I'm just going to kind of do a quick recap here. I think what I'm doing well is we are doing a lot of shockwave for soft tissue. We're starting to do it in arthritis, not doing much in wounds. I'm having good acceptance for 6 sessions. There wasn't really a consensus saying 6 is the number. Many do 3 still, many do 4. Some do 6 as well. Some of the conversations in between, some people like to do 6 only because they start to see improvement at the last session, and it kind of builds buy-in. What's not working, I'm not really doing a lot of eccentrics in terms of strengthening. I used to send everyone to PT. I'm not doing that now, just to see if I get better or the same results without adding PT. So I might start adding PT again on certain patients or giving them more specific exercises. I am not doing it post-op. I think there's a room for doing it for post-op. I'm not doing it for severs. I'm not doing it with arthritis, and I'm not doing a lot of stress fractures because maybe I'm not seeing high athletes or high intensity athletes. So those are areas that I think I could improve on. what can you do differently? I think you can keep asking people. The pain should be under a 5, so tell them extraverbally to tell me the amount. Don't worry if not, it's not so high. I think I'll still get good results. So kind of toning it down, making them hurt less. Offer to do it for arthritis and growth plate issues, and then do it for post-op and for wounds. So after, that's the kind of the plan. I'm going to ask about pain. I'm going to do kids. I'm going to do wounds, fractures, things like that. There are some websites I put in here. So some of the people that I met there, I put some of their websites. You can kind of see how they market the Shockwave. So one I really like, which is Concierge Physical Therapy, where they have all the toys, and he's actually married to a podiatrist, and they do all these injections, and really for like really C-level executives and athletes. I thought that was a neat thing. Their format is like 600 per hour plus the biologics, which I like that. I like that idea. So talking about like only going for people that have high income, they're kind of tend to be more motivated. There's something called, some other tools where like Empowered Relief is to help with pain reduction. Dr. Monaco, he had, if you go onto his website, you can see all of his consents that he's using. Atlanta Sports Medicine, this was a good one. Sexy in his website. Delaware Tendon Research Group that I was talking about. UCLA, Joshua Goldman lectured, which is a great lecture. He sees a lot of the athletes. Dr. Knobloch, Dr. 1040, which is locally here, does just a ton of research. That's what I found, where a lot of us don't do it. And then they had some different articles. So all of that is in my within one of the pages here on this Shockwave, these Shockwave resources if you want those. There's even more within Podiatry Practice Mastery, but this is a good way to start for you. Just a little, those are my ideas about the Shockwave course. I'd love to know if anyone else has any other ideas I didn't include, or ideas or thoughts on it. Okay, thanks.